Great. Thank you very much. I think I'm going to benefit from the additional time from the previous speaker. But I think it's my pleasure to be here and at least to virtually take you to Ghana to talk about the productive role of cash transfers. I think we've heard a lot about how cash transfers can be protective, but then there is this big move towards really understanding how productive this can be. So just by way of motivation, we know a lot about cash transfers, and I don't think this is the right audience to really talk about how important cash transfers are. But, there's a large literature that has shown that, cash transfers are important, right? They have really great health impacts, really reducing mortality. But then there is a mega literature also showing that cash transfers could be productive. Besides being protective of households, they could also help households to increase on their productive livelihoods. And then there is also this big literature that has really looked at, these labor dimensions of cash transfers. And increasingly, just from the first presenter, there's also this literature that is really talking about the psychological impacts of cash transfers. But what is clear about all of this literature is that cash is never enough, right? Just giving households cash, it's not the way to go. There is really the scope to improve on cash, because despite all these huge cash transfers, poverty still persists in many developing countries. And because of this, there's been really the emergence of cash plus interventions, looking at different variants of these. So there have been studies looking at various services, including psychological trainings, different kinds of edutainment, but also mentoring, different an aspect of training as well. But really, I think in the afternoon, we'd also hear from Abhijit, there's also really this movement towards graduation programs, right? How to graduate households to reduce some form of dependency, but really to improve on productivity. But in Ghana, the cash plus here, it's about health insurance. So what we do in this study is we evaluate the cash plus health insurance intervention in Ghana known as LEAP 1000 between 2015 and 2017. And what we do is we just leverage a quasi-experimental design. We are not lucky enough to roll out an RCT. We just rely on proxy means testing, to separate our treatment and our controlled households. And our key outcomes here are about households' investments. And what are we hypothesizing here? That households' investments really increase, when you give them cash transfers. And one key mechanism here, it's really about changing their future orientations. Our first speaker spoke a lot about aspirations, and this is something that we also find that explains the impacts on these different kinds of household investments. And just to talk a little bit about the literature on the psychology of poverty, is that, we always just think about poverty as a material lack of resources, but, the literature is really moving from that dimension of material lack to really the psychology of it, right? So it's really about a capability approach. It's really about that the fact that you don't aspire to move away from poverty, then you get stuck in poverty. And this literature has shown that giving households different kinds of material cash can affect the behaviors. It could improve on their mental and psychological well-being, but then it could also kind of embed households more into communal and social support systems. So just a brief background of the LEAP 1000 program in Ghana. This is a flagship cash transfer program which builds up on, the baseline livelihood empowerment against poverty program, and was implemented between 2015 and 2017, and it focused on pregnant women with children generally less than 2 years of age. And what it does is it provides households with different cash amounts, but then it encourages them to enroll in health insurance. And getting households into these various treatments was really based on a proxy means testing. What that was, a basic survey was done using basic consumption and household asset models to separate households according to their poverty standards. So households that are both were away from the treatment and put in control, and households that were below the proxy means test were now treated as treatment households. So just a brief preview looking at our treatment and our controlled households, we see that just along the thresholds, there's kind of this really equal bandwidth, showing that, even though we are not implementing an RCT, the treatment and the control groups are comparable, right? But also, when we look at the outcome, one of our key outcomes here, talking about productive employment, livestock ownership, we show that across the PMT scores, they are equitably distributed. Households are equitably distributed. Again, suggesting that, even though we don't randomize, our baseline controls are really balanced, or our baseline outcomes are balanced, making sure that we can really make some causal statements. So for the evaluation, we use a panel survey collected before and after the intervention in 2015 and in 2017. About 2,500 households, very little attrition, 6%. This is substantially low compared to other kinds of surveys in Africa. And like I mentioned, enrollment into the cash transfers was based on a proxy means test. And what it does is it just compares households above and below the threshold. So normally, if we look at the threshold, then one would just think of implementing an RDD. And previous studies that have used this data have just implemented an RDD, but mostly in the framework of an IV, right? Just to really get delayed effects. But we go away from it. But we also show robustness checks using the regression discontinuity design, really in the spirit of an IV. And what we are getting, it's really just ITT effects, right? Because we don't observe perfect compliance. Like I said, cash transfers were given to those in the treatment group, but households still had to enroll into health insurance. And because of that, we don't have 100% compliance. And because of this, we're estimating both ITT, but also late effects. So the first effects we get are just ITT, and what we want to show is that if you just rely on ITT, it's really different, right? Because then there's always this issue of compliance. And really just to show that, our baseline characteristics are balanced, this table just shows that across treatment and control groups, we observe perfect balance. But beyond the ITT, like I said, we also estimate late effects, because we are not just interested in how cash impacts, we're also interested in cash plus, right? And also insurance for those in the control group. And because of this, we estimate these heterogeneous late average treatment effects, and we get weights, right? We first of all estimate a multinomial logic model, and we get generalized propensity scores from them. We attach weights to them as a way of controlling for this non-random exposure to the cash treatment. And again, when we look at the baseline balance for these multi-treatments, we find again that our balancing is confirmed. And just a brief preview of the results, we show that we are considering really 4 outcomes here. Firstly, just livestock ownership. Do households own livestock? But also the tropical livestock units. That's the amount of livestock that is owned, really an intensive measure of livestock ownership. But we're also looking at aspects of commercialization, households buying and selling livestock, like what is happening in the market. And we see that, the program improved livestock ownership. Again, households are becoming more productive. It kind of engages households more in the market. There is this dynamic kind of productive market paradigm where we see that households are selling livestock. And when we look at different aspects of the ownership of durable goods, which we could consider non-food items households own, but we also look at savings, loan aspects of financial markets, we see that it increases the amassment of durable assets, it increases savings, and it reduces the fact that households are taking loans, which is something we really want to observe. And when we look at the psychological outcomes, we find that this LEAP 1000 kind of increases inpatients, households become more impatient. It increases present orientation, reducing future orientations. Households don't tend to think a lot about the future. But also, it really improves happiness. Households are more happy. If we look at different aspects of expectation, which is really different from future orientation because it involves more probabilities, while kind of the future orientation is really about possibilities of life. It increases expectations and different aspects of agency. And by agency, we are referring to really non-cognitive skills, locus of control, self-efficacy. And now, when we now look at this whole thing about multiple hypotheses, because we have a lot of outcomes, we show just with our unadjusted p-values and sharpened p-values that we don't have any risk of any false positives here, because we're always concerned that some of the effects we are getting are false positives, but we don't find that in the analysis. But also looking at the late results where we look at the psychological outcomes, we really confirm. But again, here you notice that the magnitudes are larger, suggesting that the ITT may not be really the best measure for us because of the aspect of non-compliance. But we see that when we look at the difference between cash plus and cash only, we see that the cash plus really leads to better psychological outcomes than just the cash. And now, beyond just estimating the structural relationships, we wanted to really go ahead to say some words on the pathways. So we now kind of interacted some of our psychological variables with the cash plus and insurance. And we showed that if you look at future orientation, we see that it improves or it increases the fact that households are engaging in various productive livelihood activities, buying and selling of livestock, increasing on their financial savings. But also when we look at expectations, we find really similar results that, it really mediates the relationship, between the SLEEP 1000, the cash plus health insurance, and these various different productive investments. And based on this, we conclude that, in the case of Ghana, that the SLEEP 1000 was able to improve productive livelihoods, increase households' investments, and then we make some really big arguments about the difference between our intent to treat effects and the local average treatment effects. And we are so happy about establishing the fact that, cash transfers and cash plus have this big role on psychological outcomes, right? Not just really looking at material aspects of poverty, but also improving the mental models of households. And to conclude, we also show that, cash transfers, which has been shown to really be protective, and I've heard a lot in this seminar that, it's really not just even about being protective, it also has this transformational legal aspect of it. It's also a question of dignity. But in this study, we show that it's also productive, right? It takes households from protecting households to making them being productive and really ensuring that, they can escape poverty. Thank you very much. I'm looking forward to a nice discussion.